to show for it. And that is shown very clearly in the outcomes. And outcomes is usually measured in your maternal, child and infant mortality rate and the low life expectancy. As we know, our life expectancy in South Africa is 54 years, having slightly improved from 48, 49 when the new government took over. The inability to get primary health centers and the district health services to function effectively has contributed significantly to the failure of the public health service. Inconsistent management and inadequate capacity has meant that implementation in health systems, health outcomes have fallen short of expectations. South Africa's health challenges are more than medical. Behavior and lifestyle contributes to ill health in a major way, what they call the societal contributions to health or diseases. People need to be informed and incentivized to change their behaviors and lifestyles. Having very limited time, I'll have to summarize and move across. The South African government faces or as a community, we face a quadruple burden of diseases. HIV and AIDS is the first one related to diseases such as TB and STDs. Maternal and child morbidity and mortality, non-communicable lifestyle diseases such as high blood pressure, diabetes, heart diseases to all the risk factors like we all know, cholesterol and high cholesterol, lack of exercise, etc. And of course, violence, injuries and trauma takes the fourth place. Now the Ministry of Health has embarked on a massive reform covering these health systems. One of the things we found out in looking at the NDP is that there's a close alignment between what the Department or the Ministry of Health has already embarked on planning. So in this case of the NDP, there was very much a lot of alignment between the two already. So not much came out new in the NDP that was not already. In fact, if you look at it, the end product is really the NHI, which was already talked about or planned about in the early phases of the ANC government. A health system that works for everyone and produces positive health outcomes is not out of reach, and that is the vision to 2030 vision of the NDP goals. It is possible to raise the life expectancy. The 4 points of the vision is it's possible to raise the life expectancy of South Africans to at least 70 years, to ensure that the generations of under 20s is largely free of HIV, significantly reduce the burden of diseases, and achieve an infant mortality rate of less than 20 deaths per 1,000 live births, including an under 5 mortality rate of less than 30 per 1,000. Now we've gathered here today to look at what the civil society, although I'm representing the private sector, but I think in a way it indirectly has some impact on the civil society because one way or the other we are related to it. And the role we can play and as the private health care, and in particular the private hospital industry vis-a-vis the National Development Plan. I'll just summarize it because there's quite an elaborate document I have here. But look at it, the areas in which we can contribute is the promoting of wellness and health in the population. And this can be done in the following ways: by having these wellness programs at community centers, at schools, at the shopping malls, and also, particularly the new thing that could happen was these things are being held where we have free blood pressure, free cholesterol, free blood sugar testing, vision, etc. But also what I would suggest is that at the hospital level that could be done this is done occasionally once a year or something like that, but at the hospitals we could do it on a continual basis where the hospitals can have this done to the visitors to the hospitals, the public, the Joe public that visits the hospitals. The other thing that's come about is the employee wellness. it is being emphasized lately. If you look the other day that the Volkswagen company has in Newton Hague opened up this beautiful center, wellness center, and it's something that the employees can also look at opening these centers, wellness centers, where the staff can train during their breaks, and of course look at the other aspects again about the wellness programs, about the checkups, etc. But in the school aspect, the NDP talks about school health promoting teams visiting these schools regularly to do checkups, and of course again promoting health education. Again, I think the hospitals could take up this and also bring their own school health promoting teams into existence by forming a partnership with the schools in their locality, and take this over from the government in creating these teams that visit the schools and do all these particular checkups, etc. Another thing that I would suggest is also that's not on it is very important is probably to get every pupil or every learner CPR trained or certified. This could also be part of the program. There's strengthening of the health systems. I won't go too much about. That's about the managing of the hospitals. We can play a role by mentoring those managers, etc., from those hospitals, because we know that's a big issue in the public sector about the poor management system. So we could mentor them, because surely I'm convinced that we in the private sector run a more efficient system, obviously because of our profitability, and therefore we can do that. The other aspect is quality and accreditation. I won't go too much into that. The role isn't too big. Of course, we must, from the private sector, see that the quality is there, but I'm talking about vis-a-vis to improve the health information system. The government's talking about a national health data information system. We can get, the point is there's a need for the private sector to also be linked into that system when it comes about. Obviously, you know, information is very important. You can only strategize and plan when you get this information. So at the moment, there's a lack of communication in this area too. Primary health care, that is the really crux of the matter. The whole National Development Plan is based on preventative medicine. Prevention, prevention, prevention. It is prevention that will really see the success of the National Development Plan. And we know prevention takes place at the primary health care level, and also at the district service, hospital services. That's the way it's all about. And I believe that no, you could. You see what happens when you're not familiar with technology. The point is that definitely the hospitals can get involved in primary health centers. Some of the hospitals are already involved in opening primary health centers. I say we can open primary health centers and partner with the government. And these primary health centers will do all again about wellness, about more the preventative side. Of course, the curative side will be there. But it can be funded by cross-subsidization. Nobody gets free treatment. Of course, the indigenous population could be treated free or at a lower cost. But the others who can afford it will cross-subsidize the services. But I think this is where we can play a part, get into partnership with government, identify the urban and rural areas. We can open primary health centers. We have realized going into Africa also, this is a very important aspect. It's a primary health center that they are establishing all over the world, all over Africa, sorry. And I think the private sector can definitely play a role. Of course, they can also subsidize the thing from the CSI plan, the Corporate Social Investment Plan. The National Health Insurance and Financing. The big issue with national health insurance, we all know the biggest challenge for the government is the financing. And there, I believe we can still play a role. The government, one of the biggest problems with the public accepting the private sector, of course, they have come to accept now that our existence is there and will remain whether we like it or not. But the biggest issue they have with us is our costing, our high costing models. And I believe that in the national health insurance, where financing is a big issue and how they're going to do it, there's various forms. It's not part of my discussion. But the question is that we could come in with the lower cost models. We could come in with the lower cost models. And this could be brought about. The costing, I know it's an issue where the medical aids will say, why can you bring your costing down? But of course, you know, the medical aids or the medical aid patients or the higher income groups want the hotel component. and the whistles and bells that goes with it. But we can come in with a lower cost model by, first of all, taking out these whistles and bells. And the other issue we can bring about, that can bring this about, is again the issue of whether private health facilities can hire doctors. This is one of the only countries in the world where we're not allowed to do that. I think that's very important. If we could do that, we have both models where you can hire and not, we can bring costs down, because then our models, we can have global models and offer the government or the NHI a global price, which includes your doctor's fee, your pathology fees, your radiological fees as a total global fee, and bring down the cost in that manner. And I won't be very long. Just on the HR side, they talk about shortage of nurses, which is a challenge for the country generally, and NHI, shortage of doctors. We are already training nurses in the private nursing schools. We will only say to the government, make it easier, really, gentlemen or ladies, and ladies, sorry. It is really difficult to open private nursing schools. It took me 3 years to get permission to open one at Lindmed, which we are going to be doing. That's a problem. So they must overcome this red tape. Do you know that every nursing school, just for your information, every nursing school that opens must submit a curriculum to the Department of Higher Education and to the Nursing Council? Can you believe it? Instead of them saying, here's the curriculum, follow it. Everyone must submit their own one at a cost of 250,000. We're busy with it now because of the new curriculum. So you can imagine the red tape. But the other important issue is the doctors. The question of training doctors. We keep on saying we have a shortage of doctors in countries, yet we don't allow private medical schools. The private medical schools, people will pay out of their pockets for their education, taking the burden, which the government say it costs them so much to cross-subsidize doctors trained at the public or the universities, the existing ones. Here it will be completely out-of-pocket payment. Why can we not allow it? It's happening everywhere in the world. And that will play a big role in the costing in increasing our numbers, and the inequality that the government talks about regarding doctors' inequality distribution between the private and public sector, because it will also lead to the fact that we can hire doctors and bring them in at different salaries. Thank you very much. In conclusion, all I'll have to say, at the end, public or private, it is the health of the person that counts, and we need to mobilize and use resources efficiently. Thank you, Mr.
Thank you, Farouk. What came out strongly is a lot of talk around public-private partnership, and I'm sure Terence from the Department of Health will touch on that as well. Farouk, you spoke a bit about a lower cost model. You know, whenever we hear talk on the private hospitals, the one thing that always comes about is shareholder expectations and return on equity, return on investment. Would people be happy? Perhaps we can look at it at discussion time with the lower profitability model. Is there an expectation that, you know, shares in private hospitals should be performing at a certain return? And if you don't provide, with, you know, just maybe something for you to mull over, whether your shareholders will be willing to accept, in the greater scheme of things, a lower rate of return. My next speaker, Zamir Bray, is an academic. Please, like I said, we are running short of time. He's promised to be short, so I'll let Zamir get on with it. His profile's in your brochure, and we'll go from there.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning to all. I should start by saying that the document to the left is a little intimidating for me. I haven't done extensive research like Uncle Farouk has done here, but I'll try and do justice in a couple of minutes we've been given. Maybe also just to thank the organizers really for putting this fantastic initiative together, and for, I think, really starting the debate around that also civil society can play in advancing the objectives of the NDP. I should probably also clarify, just because some people asked me, you were in Cape Town last night and you were just a doctor. You arrived this morning, and I'm a professor. Okay, so ASRI is very progressive. But just to clarify, I'm still very much just a doctor. So I think I'm not really going to focus on a critique of the NDP, because the question that was put to us as panelists was, what is the role that civil society can play in advancing the realization of a strong, responsive health system? And so I'm gonna really just make 5 or 6 opening points. I think the advantage of the structure of this kind of session is really in the engagement. And so I'm not going to try and lecture. We do that during the week. But I think this is a more exciting way to really stimulate the dialogue. So I think that one of the 5 points, and probably the first point that I'm going to start with, is the creation of an enabling environment for civil society to make a contribution. And let me, kind of speak a little bit more about that. Currently, the time that civil society, or the opportunity civil society has to make that contribution, is once every 5 years when you go to the polls. In reality, I think there are a number of forums that have been put in place, but they're not really constructive. They don't allow for decision making. They don't have the financial muscle to effect decision making. And so the mandate and realization or inputs that those civil society forums make, in my opinion, is quite limited. And so what I think needs to happen from primary care to district care to hospital level care is that there needs to be an opportunity for civil society to give input, but there needs to be the appetite from government to accept and implement where appropriate. And I think, so this is also, and I recognize I'm kind of talking visionary stuff and maybe 10 or 20 years, but I think that if those opportunities are created for civil society to have teeth to make decisions and influence policy, then I think civil society will have more of an appetite as well to be involved. My second point is really about the NDP talks about a very important shift in thinking around healthcare and wellness. And that's really looking at the upstream factors that affect health. So the social determinants of health. So the fact that you have a job, the fact that you have access to clean running water, and you have a house, are all important in health and well-being. I think where we really need to be spending a lot of energy as civil society is for advocating that the intersectoral or interministerial clusters that get set up actually need to mimic that shift in thinking. So, and again, with the appropriate decision-making space, with the appropriate governance structures, because we can't talk about social determinants of health and expect it just to happen. There's actually got to be a very constructive or a really well thought out platform for the Department of Health, Social Development, Housing, Employment, etc., to come together and actually say, how do we address the issue of wellness or promoting of health over the lifespan of an individual in South Africa? And I should probably pause here that while there are these kind of clusters that exist, some of the research suggests that the approach taken by senior leaders and politicians towards those clusters is more of a tick box approach. I attended the meeting. Now, can we move on? And so the dynamic really has to change. The role of those clusters has to change to accommodate the shift, both in that the NDP is advocating for and the World Health Organization in redefining its Millennium Development Goals towards social determinants of health. The third point I just wanted to make around, I think, the role that civil society can play is promoting a sense of agency at the level of individuals. And I have 2 examples to draw on here. The one is we as society have almost normalized or accepted certain kinds of behaviors. And particularly what comes to mind is violence against women and children. So one kind of sits in the South African context and looks at, the rape statistics, and we kind of say, oh, okay, that's bad, but let's move on. And what I think needs to happen is that we actually need to, as a society, start saying, how do we build role models? How do we develop what is acceptable behavior so that when something is unacceptable, it stands out, and so that we don't accept that one rape is okay or two rapes are okay. No rape is okay. And if we as civil society start playing that role, I think we can significantly change the impact it will have on wellness and healthcare. So if you, for example, take the diabetes, sure, we can't choose the genes we inherit, but we can choose the diets we take. And I think it's something that is a lot harder for government to do alone. So government may be able to change the policy or the law on what goes into food, etc. But I think if civil society plays a leading role in creating that sense of agency, I think we will work well together in improving healthcare of individual South Africans. The fourth point I just wanted to touch on is about a paradigm shift from the way civil society is responding to certain issues in healthcare, which I think is often quite reactive. And while necessary, may not be very helpful. And maybe I should just touch on kind of two examples here. So there's a planned closure of a hospital. And all of a sudden, civil society comes together. There are 10 or 20 organizations that protest and toy and make a lot of noise against the closure of the hospital. The question I have is, why are we not picking this up in the budget vote of the previous year and actually objecting in a more proactive way than standing at the kind of corridor, at the gates of the closing hospital and then, protesting? Even the Eastern Cape, coalition, I mean, I think they did some really fantastic work in uncovering a lot of the ailments in the Eastern Cape's health system. But I think civil society almost needs to play the role of flagging up issues within the system, play a role of surveillance, of monitoring, and actively hold government accountable to deliver on its mandate. The last point I want to make is I think that there's certainly an opportunity for bilateral, trilateral, multilateral partnerships in the delivery of healthcare. The government is simply not able to deliver healthcare to all South Africans as we would want that. That, I don't think, means that government is not open to partnering and listening to civil society, listening to industry. And I think there's a window of opportunity to really influence the way those partnerships are built and the impact those partnerships can make in realizing the goals of the NDP. I'm going to stop there.
Thanks. We'll speed it up. Sure. It's interesting. On our first session, again, Minister Pendo made the point about government is listening, is waiting for you to come to the party. We've had now two speakers who've again spoken about public-private partnerships. Private is speaking, is government listening? No one better to tell us whether government is listening or not than our next speaker, Terence Carter, who's Deputy DG, Department of Health. Terence?
Thanks, Chair. Assalamu alaikum. Good morning. The focus of the discussion today is on the NDP. When our minister did his budget speech 2 weeks ago, he said to the chairperson in Parliament that the National Department of Health's strategic plan is based entirely and completely on the NDP, the National Development Plan. So everything that we do in the National Department of Health is geared towards the realization of the National Development Plan. So the NDP specifically around health says, essentially, there are 9 goals, but essentially it says 2 things. One is that we want to reduce the burden of disease, and we want to increase life expectancy. And it goes into significant detail on how and what are the areas that we need to focus on to achieve that. And then it outlines the priorities, those things that we will do to achieve the goal of realizing, reducing burden of disease and increasing life expectancy. And it talks about addressing the social determinants of health, talks about things like education, poverty and inequality, housing, sanitation, and so on. All those things that leads to poor health and reducing life expectancy. But it also talks about other things that we need to do within the Department of Health. We need to strengthen our health systems. We know that our hospitals are functioning poorly, our clinics are functioning poorly. We need to determine what are those things that are making our hospitals and clinics functioning poorly and deal with those. And those are things such as management, effectiveness, competency of management and leadership. Things like our information systems and how long people have to wait, for example, either at the outpatient department or the clinic just for a folder. Things like financing, making sure that in fact we have the right amount of money for health, but also that the money is being used appropriately and correctly. I think the first speaker said that as a country, we are not spending less money on health than many other equally underdeveloped or developing countries, and yet our health outcomes are poorer than countries that are poorer than our country. So the question is, the money that we have, where does it go to, what does it buy? So the whole question of not only budgeting, but financial management and human resources management are the kind of things that we need to be focusing on. Now, clearly it's not possible for me to go into detail in any one of these because of the specific time constraints, but suffice it to say, we therefore are looking at prevention of disease, prevention of ill health, and promoting of good health. There are a few key initiatives that I'm just going to mention in closing. The first one, obviously, that everyone would be keen to understand where we're going is with the NHI. The NHI, as you know, is the major transformation and reform of health in this country. We want to achieve through the NHI essentially 4 things. One is that we want to increase access to health. In other words, we want to make sure that every citizen in this country has equal access to quality health care, irrespective of where that person lives and irrespective of what that person's income is. Secondly, quality. We want to make sure that the service that we provide is a service that can be recognized and seen and experienced as a quality service. It needs to be affordable. Healthcare globally has become unaffordable. America spends the most amount of money on healthcare anywhere in the world, and yet their health outcomes are no better than many other countries that are spending far less on healthcare. So affordability is important. And lastly, efficiency. We need to ensure that we are efficient in the way that we render our health services, and the intention of the NHI is intended to achieve that. So key initiatives are the reform of how we manage our hospitals, reform of how we manage our district health services and clinics in particular. The President launched about 2 months ago, the ideal clinic model. There are key other initiatives such as there's a National Health Commission that looks at how we develop and promote wellness in the country. We look at antimicrobial resistance. In future, if we continue using antibiotics the way we do, none of the antibiotics that are currently available will work. We need to deal with that. We need to deal with, while we are looking at litigation and the cost of litigation in our hospitals, improving our healthcare and improving patient safety, but also dealing with the whole issue of litigation. And then lastly, the Competition Commission, looking at what happens to the financing of health in our country. Now, Chair, this is where I'm going to stop for now. I think clearly there's a lot more that one can say, but I think in 5 minutes one is limited, and I'm going to stop there for now to allow for question time later.
Thank you, Terence. Zamir spoke about at a cognitive level about behavioral change. Farooq spoke about taking responsibility for your own health. I'm not going to ask how many of you in the audience smoke as a start, but I'm obviously in question time. We'll in the discussion time we want to get back to that, because the key component still remains how we do all of this. I think the NDP has spelled all of this out, but the how is still the crux of it. Now, Shabir Musa is running an interesting project in Shawelo. Experimental, seems to be working very well, and I think perhaps at a grassroots practical level, Shabir, you can perhaps tell us how, as professionals, but also how civil society in your clinic is working towards improving their own health.
Shukran, Jazakumullah khair. Assalamu alaikum. I'm going to relate the issues in a bit of a story about me. I think as all Muslims, we have to ask ourselves, what do we see ourselves being impelled by? What's the impulse? And as a young boy, 10-year-old, the one thing that stuck to me even till today is my Ustad said, on the day of judgment, you will get up as everybody else. You will not turn to everyone. You will be alone despite the billions around you. And Allah will ask you, what have you done on this earth that is good? And I think that's the question we have to ask all of ourselves. And that good is not just for ourselves and our families, for our community, as Maulana Ibrahim yesterday related. It's about the society we live in. And when I was in medical school, I think this impelled me, and then beyond into as a general practitioner, and even high school, to say, how do I respond to what is really severe inequalities, apartheid that we lived in? And I was very disappointed by what happened with other fellow medical students, neurosurgeons, cardiologists. I just couldn't understand, how would you as a Muslim say that is my objective in life, is to make the most amount of money in the shortest amount of time? And that I think is the problem of our health system. It is how we function to say that is how we should treat health. As a Muslim, I found myself finding a discipline that seems today to be treated very poorly. It's called family medicine. Most of you have not even heard of it. But it is actually postgraduate training of general practitioners. If you go to the UK or most developed countries, those GPs are not out of medical school. They're actually trained as GPs. Because general practice primary health care is not dummy work. It's complex, far beyond even the cardiologist and the neurosurgeon. And I know it, I work every day in it. And what I'm going to suggest is that we think carefully about the paradigm we think in terms of health. Primary health care is my big bugbear. When I came into Johannesburg 2004, I was trying to implement family medicine. That was the task. And the biggest struggle we had is that after 15 years, the system of healthcare was really in a mess. We had a district health system, nice on paper, abysmal in practice. And yet, despite putting more doctors in place, all it landed up to do is to have more doctors pushing queues. Nurses seem to take longer to tea breaks. The problem is, we said the system sucks, and we need to think the system through again. So it was very encouraging when the minister revealed the NHI. He said, now there it is, something good, something that will deal with our society fundamentally. And in fact, I did a piece of research looking at, well, considering GP contracting, what would be the response of GPs to such contracting? And it was a big sample of the South African GPs, 900 out of the 9,000. And we asked them, what would you do in response to a capitated population of 10,000, which is more than usual? How would you respond to that? Well, they said, firstly, I would increase my staff and include more nurses and build up a multidisciplinary practice. I don't need all doctors for everything, so task shifting makes sense. They then said what it'll cost, what they would charge was almost the same amount. It was 4.303 million at the time, but that was almost the same as Johannesburg Metro costs at that time, which means that GP contracting is not costly. We've made a big story out of that because of poor research being done. So we also asked, what do you see as the challenges in contracting with the government? And their problem, they said, we can't trust government. And that's a big problem. There isn't trust. They said, we need to fix up a good contract and not be abused. The second thing they said was, well, you know what, you've told that 3 visits per annum is the number of people that will come to the clinic, to my place. That's too little. And that's true. How do you respond to that? No, we will try and improve the health of people. We will go out there and we will help promote health. Imagine your doctor now, from not treating you for illness, is saying, how do I keep you healthy? That's the difference that the NHI promises. The third thing was that, well, how will we deal with our current practice? We'll have to be better organized, better managed, and I think that's a good impulse for doctors. So great things come out of doctors when you give them a scenario in which you can get better cooperation. So there's a great deal of promise. Government's not doing it. In fact, even the NDP seems to be backtracking and saying, well, it's still some way. We have to build the public service. I'm sitting in it. It's a mess. I don't see any way in the next 10 years you will succeed. I'll give you an example. I told the manager yesterday that we want to set up what we've done now, I'm going to relate to you, in other parts of the clinic. She says, no, it's very difficult. I'm running a 50 million rand clinic, but I can't afford to get you 3 filing cabinets. And if we have to do this with the, rearrange the filing of with the clerks, it'll take 10 years to achieve. It's a manager at a facility costing 50 million rand. What we did is, I basically have said, we have said as family physicians in the country, community-oriented primary care is a model. In fact, the government relates to Brazil. Guess what? It is South Africa that designed that whole idea. It came in the 1940s in South Africa. It went to Spain and all sorts of parts of the world. Then went to Cuba later, and then to Brazil. And now we say we're inspired by Brazil. This was done in our country. We must claim it for ourselves. What this says is, and it's similar to what government is talking about, saying we want to have primary health care center of everything. We want to have PHC outreach teams that will go into the community. When you look on the ground, we've done research evaluating this. Do you know what's happening? It's not integrated primary health care that's new. There's no re-engineering about it at all. What's happening is that nurses are being told, some nurse, junior nurse said, you know what, there's these 6 community health workers, or in fact more, just tell them to go out into the community, collect paper. So they go out, and not even in a ward-based system. They just go out, collect this paper, it piles up, and when they see a referral, they refer it to the clinic, and it gets seen by someone. First time, maybe quickly, second time, back in the queue. You think those people who had TB never coming to the clinic are going to come back? So really, it's no more than a flash in the pan. And the truth, it's flailing. The MEC came over to our place last week, and I've been struggling, sorry, I know I'm taking it long. I was struggling to try and get managers to cooperate with me for a full year. The MEC came and she said, this is what we want, it must be rolled out. I know that would be just talk. At the end of the day, the managers will sabotage it because that's not in their interest. Because the system as it works, as it sits, suits them very fine. Because there's no accountability at all. We've said, let's do things differently. In Shawelo, and in a very few sentences say, in Shawelo, we said, no, we will use the same tool. Community health workers will go out into the community. They will collect data, they'll map the community, but they are part of this team that sits in 2-3 rooms. We will then work with them very closely as clinicians. So there's a registrar, family physician, that's me, that doesn't spend much time there, and a clinical associate that basically provide care to this community. But in addition to the community health workers collecting information, which we can analyze, and I can show to you that of the 15,500 people that we've registered, there are 4,200 who have problems, and I can tell you that I've got 908 hypertensives, and within a day I can show you exactly where they live. Now that kind of information ain't available in the public service. And this is the kind of premise on which we can now move. So we've said, let's engage with stakeholders, and let's start thinking health promotion. We've got 150 old ladies who are sitting every day doing exercise, and who come and when they visit us, talk about how important that is. So, inshallah, the question we should be asking ourselves is, what are we going to be able to do it? And I think we must stop saying what government can do about it. We should be asking, what should we be doing it? And that might be holding government to account. But it's also about, are we willing to get involved and try to make this? An example is a mobilization strategy of GPs behind the NHI would be something that the IMA could do very strongly. And I would strongly urge them to think about that and support them. But I think there are many such ideas that you can generate amongst ourselves.
Thank you, Shabir. I'm sure during discussion time we will have a lot of discussion on that. Now, my apologies. I see our next speaker doesn't feature a profile in the brochure, but of course, an important tier of health services are our colleagues, the nurses, and the entire group. And to speak on their behalf, I'd like to welcome Ms. Maditopa Masemola, who's Acting General Secretary of the DONOSA. Thank you.
Thank you very much. I think all of us will agree that within the health system, nurses play a critical and vital role, because when we have been listening to all the speakers that just spoke today, all of them mentioned the importance of nursing as a link. Nursing as a profession, or nurses in this country, play a vital role, because each and every services, they play a coordinating role with a multidisciplinary team. But one will also acknowledge the challenges that we find ourselves within the health system, because predominantly you find that there are challenges of shortages, where you'll find commissions and omissions as far as the scope of practice is concerned, where issues of task shifting or task sharing is not clearly defined, and you find that nurses find themselves under circumstances of ethical conflicts where they are faced, especially in the remote areas, clinics, where you will find only one registered nurse having to deliver or to attend to somebody that has just got a step wound. Those are challenges that nurses are finding themselves in. But I think what becomes important is also the working conditions under which you find nurses working. Because when you talk about the NDP, you must remember you're talking about preventive and promotive. And if you are going to talk about preventive and promotive, that's where nurses comes in. Because they are people that are specifically located at your primary health care setting. They are running those health centers. And as long as they are not capacitated well enough and there's enough manpower, especially at the remote areas, that's where challenges and outcomes of health are compromised. The working conditions that we are talking about is like, for instance, your security at the health institutions, limited resources. It can either be limited resources that actually compromise quality, or even human resources per se, because one also need to look at the issues of skill mix and also the issue of different categories at a particular moment. The issue of re-engineering of primary health care, when you look at the whole system, it's nurse-based, it's nurse-driven, even the NHI. Because when you talk about the ward-based teams that are supposed to be sent, nurses are going to run they'll be managing those teams. And the other problematic issue that we find ourselves, especially at this era, is that with the new qualification framework that is now that was supposed to be already implemented in 2012, and it has been postponed and postponed and postponed, it causes problems of supply and demand. Because at the present moment, while conversations are still taking place as to where does a nurse have to be trained, whether in higher education according to new qualification, or the priority still remains with the Department of Health, whether to train in nursing colleges. We find ourselves with an aging population of nurses that are leaving the services through either retirement or even morbidity, and no one is replacing those skills at the end of the day. And all communities out there are crying over poor services, long queues, and all that, but communities are not advocating to show that government takes responsibility of ensuring that there's proper planning and for the future. The other issue is the issue of the Act, South African Nursing Act 33 of 2005, nurses will be now required to do continuous professional development, and it will be guiding whether they will be registered in the role to practice in South Africa or not. And when you look at challenges that we are having at the present moment, where, especially in the public sector, where a person is employed generally to work anywhere where there is shortage, we have challenges. We do, as the nursing profession, we are still asking ourselves questions to say, how is this going to be rolled out at the end of the day? Because if you are a nurse working in maternity ward, if there's shortage in the children's ward, you will be placed. No one is supposed, if you work in public service, it's not like you'll be a person who is a specialist in the specific field. You have to be someone who's acquainted with all departments, and that's where quality is being compromised. And due to the fact of time, there's a lot that one can talk about, challenges that nurses are facing and the role that they can play. And one can also just look at the model that was done when nurses initiated HIV treatment, where we have seen a lot of improvements in the health system. It's only that things need to be clearly defined to say what tasks are we shifting to nurses, and when we shift those tasks, what other categories are we bringing into the health system in order to relieve the task of nurses, so that when they do other tasks, at least we know that there's equity. Thank you.
Colleagues, as you know, we started a bit late. The sessions were meant to run over 90 minutes. If we do that, we'll end at 12:50. As you've seen, I've been given a note to say we need to finish at 12:30. Lunch from 12:30 to 13:30, including the prayer facilities upstairs, and lunch in the foyer. So we have 30 minutes. So can I please remind you, what we'd like to come out of here is, and in the time we have left, is what civil society can do. We know the ailments in the health society. Many of the panelists have spoken about it. I'm sure those of you, all of us, at some level or the other, have experienced it, whether in public or private. Private, whether it's purely on a cost or service-related basis. The huge challenges. Can I perhaps ask you to direct your question, challenge our panelists, but direct your question more towards the how of what we can do. Yes, government is failing in many respects. We know the inadequacies. Terence has alluded to some of them. I'm sure Farouk, as everybody else, has spoken to public-private partnerships. How, at what practical level? Those of you involved in it, I pose a question about perhaps lower profitability with shareholders in private clinics, perhaps not your larger life healthcare, Mediclinic, Netcare, those listed on the stock exchange. Would they be willing to take a cut in profitability and shareholder return in the aid of meeting up? We know there needs to be a paradigm shift. Speakers have alluded to it, and of course the corruption, inefficiency, all of that. We don't have too much time. Please, can I ask you, if you raise your hand, we'll start giving you numbers so we can go, and I'll take a whole bunch of questions. Make